All right, I think for the sake of time, let's get going, guys. Let's start. So you may go on and present.
Thank you and good morning, everyone. I'm going to present a case-based discussion on complex abdominal wall defects. So as an introduction, abdominal wall defects are defined as congenital malformations which result from incomplete closure of the anterior abdominal wall during embryogenesis. And this leads to herniation of abdominal viscera. And they pose a significant challenges in the prenatal diagnosis, neonatal management, and they've got long-term complications. And the common types include gastroschisis, omphalocele, and complex ventral wall defects such as pendalogy of central and Bodestock anomaly. So in terms of epidemiology and risk factors, the most common ones are gastroschisis and omphalocele. The incidence for gastroschisis is around 1 in 3,000 births, and it has been noted in literature that there is a rising incidence in young mothers who are less than 20 years, and risk factors include low socioeconomic status, poor nutrition, smoking, alcohol, and drug use, as well as environmental toxins which are used in agriculture, and there's a familial clustering which is non-Mendelian, and the recurrence risk is less than 1%. While it's omphalocele, it's rare with the incidence of 1 in 4 to 7,000, and it's often associated with chromosomal abnormalities and other congenital anomalies. And these factors include advanced maternal age. It's found in association with trisomy 13 and 18 in 30 to 50% of the cases. And congenital anomalies which are associated include cardiac defects, neural tube defects, and it's also recurrence risk is higher when there is a genetic abnormality or it's associated with a syndrome. So in terms of embryological basis, the anterior abdominal wall forms between the 4th and 12th weeks of gestation, and around 6 weeks there's a physiological herniation of the midgut, which occurs when the midgut elongates more than the abdominal cavity, resulting in herniation of abdominal viscera. Around week 10 to 12, there's a return of midgut in the abdominal wall closure. So if you do ultrasounds and around 10 to 12 weeks, you might note a herniation of viscera, but this is physiological. So if there's failure of lateral body folds to fuse or abnormal regression of the yolk sac and umbilical ring, leads to defects. So if there's a failure of lateral folds to fuse, there's an omphalocele, which is a defect at the umbilical ring covered by a membrane. And if there's disruption of abdominal wall formation, which can be due to vascular compromise or mesodermal defect, it gives us a gastroschisis, while it's a failure of cephalic caudal and lateral folds to meet, gives a large defect in Bodestock anomaly. So we are presenting a case of a patient that we are currently following up in the fetal medicine unit, Mrs. CS, who is a 19-year-old in her first pregnancy. She was not sure of dates. She had an ultrasound scan at 23 weeks, which gave the estimated date of delivery of 5 November, putting her at an estimated gestational age of 28 plus 2 weeks today. She's a housewife from Rua and was referred after abdominal abnormalities were noted during an anomaly scan, which was a first ultrasound scan done at 23 weeks. She had no history of any chronic or maternal illness in pregnancy and was not on any medication prior to conception or during their pregnancy. And there were no maternal or paternal family history of anterior abdominal wall defects, and she's not in a consanguineous marriage. On antenatal investigations, which were done on booking, which was done at 22 weeks, she had an HIV test, which was negative, RPR was negative, and hepatitis B antigen were negative. Blood group was not done as she booked at a local clinic. So the anomaly scan, which was done, the biometrics which were measured included a BPD, which was 55.6. They did not put a percentile since it was also a dating scan. its circumference was 210 millimeters, and on the abdominal circumference, it was not measured, as they noted a defect. Femur length was 44.2, so they noted a defect on the right side of umbilical cord with free-flowing bowel, leading to referral to the fetal medicine unit. So the patient, when she was seen, she was now at 26 weeks, and on ultrasound scan done in the fetal medicine unit, on interrogation of the fetal skull and the head and the face, it was noted to be normal, with the normal head circumference, normal structures. And on the face was also noted to be normal, with the nasal bone, which was present, and it's 7.8 millimeters, which was normal. But if we look at the picture on the right of the screen, we can note that there was this mass which was coming to the face, and this is the liver which was herniated in outside of the abdominal cavity, and it's coming towards the face. On measuring the abdomen, on the left, this was measuring the abdominal circumference, but there was a defect which was noted from the abdomen, and the defect was measured. It was 3.3 centimeters. And also, if we note, there's this 3 cord insertion which was inserting into the defect, which was noted here. So this was the umbilical cord insertion. This picture also shows the abdomen during scan. We can note that the liver is outside of the abdomen, as well as a free-floating bowel, and also the bladder was pulled up by the defect outside of, and part of the bladder was outside of the pelvis. And on the other picture is a free-floating abdominal, free-floating intestines, which were noted. And another cross-sectional view is showing the face of the baby and the liver, which is on the other side. So the herniated liver was more pushed to the face of the baby. When applying color Doppler to which we can see that the bladder with the 3 cord umbilical vessels which are around the bladder. So the bladder was also pulled up into the defect, and part of it was outside, but it was present. On interrogation of the heart, you can know that there was a normal 4-chamber cardiac view in the heart. On interrogation, it was normal. Also, on interrogation of the spine, it was normal, ruling out any choleoskyphosis or any spinal defects in this fetus. And this is another view showing the spinal, the spine, which was normal. And on the left side, we can see bowel, which is floating in amniotic fluid. So on the differentials of our case, the patient had anterior abdominal wall defect, which is complex with exteriorization of bowel, liver, and part of the bladder. And on the differential diagnosis, gastroschisis was less likely, because usually in gastroschisis, it is a full thickness paraumbilical defect, and usually there is herniation of bowel, and there's no membrane, and the umbilical cord is normally sighted. But in this case, there is bowel, and there's also liver and part of the bladder, as well as the stomach, which are herniated. So it makes it less likely. Then in terms of omphalocele or exomphalocele, it's a midline defect with the umbilical ring with the herniation of the viscera, which are covered by the membrane. But in our case, the viscera were free-floating in the amniotic fluid, making an omphalocele less likely. But we can maybe entertain it if the membrane is ruptured, which was covering the omphalocele, resulting in exteriorization of the contents into the amniotic fluid. Then for pentalogy of Cantrell, it's a midlines which is supraumbilical defect with a lower sternal defect, diaphragmatic and pericardial defect. But in our case, when there was an interrogation of the other system, the chest looked normal. There was no diaphragmatic or pericardial defect, and the heart looked normal, and there was so that rules out the pentalogy of control. And for both talk anomaly, it's usually a severe ventral wall defect with evisceration of abdomen and thoracic organs. But in our case, thoracic organs were not eviscerated, and the spine and limbs look normal, ruling out both talk malformation. And other complex like the cloacal extrophy, which is usually atrophy of blood and large intestine and the emphalocele with genital anomaly. And usually the bladder is absent on scan. But in our case, the bladder was noted to be present and normal. So that leaves us with maybe possibility for an omphalocele with a ruptured membrane, or it's just a complex anterior abdominal wall defect. So they might need for postnatal confirmation to see what exactly this defect is. So in terms of associated chromosomal conditions, it can be, there will be need for invasive testing, like amniocentesis for us to note, to do karyotype and microarrays, to note any chromosomal abnormalities, cardiac anomalies, cardiac was normal, pulmonary hypoplasia, the lungs from ultrasound scan, which was done, they look normal. In GI malrotational atresia are other conditions which can be associated with these conditions. So I will hand over to Chair if there are any questions on the history before moving on to discussion.
Dr. Chidowore,
Yes, Dr. Erenga.
I think we've lost you.
Can you, sorry, where did you last hear me? So that I can go back.
Probably on that slide. Yeah, on that slide. Thank you.
Okay.
On associated conditions.
Okay, so in terms of chromosomal anomalies which are associated with ventral abdominal wall defects, with exomphalocele, about 30 to 50% of the cases, they are associated with the trisomy 18 and trisomy 21, and rarely are associated with the trisomy 18 and 13, and rarely associated with the trisomy 21. Then in terms of cardiac anomalies, they are also associated, they are seen in exomphalocele, both talk anomalies as a pentalogy of Cantrell. And pulmonary hypoplasia also is one of the defects that's why I've been noted in literature to be associated with anterior abdominal wall defect. So for investigations, a detailed anomaly scan is needed, as which was done in our case, and we noted that from the central nervous system, it was normal. There were no neural tube defects which were noted, or cardiac anomalies which were noted, or skeletal, or which were noted. There's only the abdominal wall defect which was noted. And the amniotic fluid volume assessment was normal. Fetal echo, the former one was not done, but interrogation of the heart was done during the anomaly scan, which was normal. And in terms of karyotyping and amniocentesis, our patient has been offered, and they are still to decide. And also, so this patient for further follow-up might need growth scans and serial monitoring. Thank you. I think for history, this is. In terms of antenatal management plan, the patient will need the multidisciplinary team, which include the fetal medicine, pediatric surgeon, and neonatology, as well as genetics. For the pediatric surgeon, I think their most input will be on when they will be taking over the care of the baby when the baby is born, in terms of counseling the mother and the procedures which can be done, survival, as well as complications which can arise from this defect. And genetics that will be needed for counseling in terms of those who are found to have a genetic abnormalities, as this will increase the risk of recurrence. So in terms of parental counseling and prognosis, testing needs to be done for prognostic surgical needs as well as genetic testing, and the delivery planning to be done at a tertiary center, which has got all the multidisciplinary team members. And for our case, that would be Salim Gabe's hospital, where we have pediatric surgeons and the other members of the team available. And timing of delivery will be at term unless there is earlier indicated, or if the parents choose to make another decision, pregnancy determining decision, which might result in earlier delivery, or in the mode of delivery can be possibly vaginal delivery, but in our case, there is no sec, so cesarean section might be a safer way for delivery. And they need to be coordination with pediatric and pediatric surgeons as well as pediatricians. And on postnatal management, there's need to protect the exposed viscera. In our case, there's the stomach, bowel, liver, as well as the bladder, so they need to be protected. And there's a need for NG tube decompression, IV fluids, and antibiotics, and surgical repair, which is based in the expertise of the pediatric surgeons. And in terms of prognosis depends on defect size and organ involvement and the associated anomalies. Pulmonary development as well as survival in terms of omphalocele is greater than 90% for isolated small ones, but less than 50% if there are major anomalies which will be noted. And for the other anterior abdominal wall defects, in terms of survival, for gastroschisis, the survival is usually good with the 90% if it's a simple defect, and it goes down to 70 to 80% in complex defects where there is intestinal atresia or stenosis or necrosis. And for body stroke anomaly, it's the survival next to none as the condition is lethal. In pendology of Scantrell, survival again is guarded in depending on severity of cardiac and other defects which will be available. And for cloacal extrophy, the survival it's higher with using modern methods of surgery, but there is a risk of requiring multiple operations, and also associated with complications in the neonatal as well as adulthood. So for counseling points for the patients, we need the nature of the defect, what exactly is the defect, the surgical options for repair, and also the staged repairs, NICU stay and duration, counseling them that this is going to be a long stay, and potential complications which include infection, bowel dysfunction. We can get a bowel necrosis needing a resection, and they can get short bowel syndrome in the long term, and also there are long-term follow-ups which are needed. Okay, so going into literature, looking at case reports on anterior abdominal wall defects. So there was a case which was reported about a giant omphalocele by Bagheri in 2024. where they managed at a tertiary center with a staged reduction in primary closure, and that they managed to discharge the baby. And also a case series which was done by Chidowore et al. In 2024, where they compared isolated versus non-isolated follow-through cases. They noted that with isolated cases, survival rate was around 80%, and 20% in non-isolated group, but there was poor prognosis linked to cardiac anomalies and chromosomal defects. And this highlights the importance of prenatal genetic testing and anomaly screening, so that we'll be able to counsel our patients well. And another case report on blood stock anomaly in 2015, we are the classic lethal blood stock anomaly, severe venereal defect and absent cord, which was diagnosed at 14 weeks. And after counseling, the parents decided to continue the pregnancy, but unfortunately, there was neonatal demise shortly after birth. So this emphasized the role of early ultrasound scan in diagnosis and counseling. As in our patient, she presented for an ultrasound scan only at 23 weeks, which was now in the second trimester. And the defect was noted a bit late. And another case of blood stock syndrome where the baby survived with multiple complex surgeries over the first year of life, but severe long-term morbidity, including neurodevelopmental delay, were all noted in this case, also illustrating importance of early diagnosis and counseling for patients to make pregnancy decisions earlier. Another case again of herniation, hepatic herniation, which was noted in Moscow in 2024. The planned cesarean delivery to avoid sac rupture, and also repair was done in stages. So in counseling our patient, we have to note that those patients who have got a complex abdominal wall defect with the herniation of multiple organs require multiple surgeries or gradual staged repair, and this can also result in longer hospital stays, and there are also complications which are associated with this. So in terms of our case, the most likely diagnosis might be giant omphalocele with a ruptured membranes versus a typical gastroschisis or blood stock anomaly. So in terms of our leaning more on the omphalocele with a ruptured membrane, can offer our patient amniocentesis with microarray, MDT, and also counseling for the parents to make a decision. And also antenatal evaluation isn't done. Delivery, if the patients decide to keep the pregnancy, will be at the tertiary center at Salem Gab with pediatric surgeons available, and modern timing will individualized for the patient depending on follow-up outcomes. And immediate neonatal care will involve protection of the viscera, decompression, and IV fluids or antibiotics, as well as surgical review. So this is a patient who needs to be delivered while the pediatric surgeons are available or are on high alert to take over management. So from our case, the key learning points will be importance of an early anomaly scan at the first trimester ultrasound scan around 13 weeks. Complex anterior abdominal defects require an updated approach, and prognosis depends on size, and anomalies, and deliveries to be done in specialized centers. These are some of the references that I used. Thank you.
Thank you so much, Dr. Chidowore. We will open the floor for discussion. I don't know if the PED surgery are here already, so that maybe we can give them a floor to give their perspective on the case before maybe people ask questions and entertain discussion.
Thank you very much. Good morning, everyone. I'm very sorry. Network was bad, so I missed the part of the presentation. I just need some clarification on the ultrasound scan findings. You said that there was herniation of the liver, the bladder, and the membrane sac wasn't intact. What was the position of the umbilical cord in relationship to the abdominal wall defect?
Okay, thank you, Doc. So I think on these pictures from the ultrasound scan, on the left of the screen is the abdominal circumference which was being measured. And if we look on the left, on the right side, this was the defect, which was measured at 3.3 centimeters. And this the 3-chord view, which is showing the umbilical cord insertion. It looks like it's inserting into the onto the defect.
Okay, thank you very much.
Maybe to just clarify and say probably it's more to the left, it's to the left of the defect, or the defect is to the right of the umbilical cord in this case.
Okay, so if it is the case that the defect is on the right side of the umbilical cord, it's likely to be a gastroschisis than in omphalocele. For omphalocele, the umbilical cord will be inserted right on the defect. Sometimes if it is ruptured, you may see that the sac is available but it's not intact. But in this case, you can't see the sac completely, isn't it?
Yes, there's no sac which is visible.
So it's likely to be a gastroschisis rather than a giant omphalocele. It's possible that sometimes you can have a gastroschisis with a wide defect whereby you can see herniation of the liver, the bladder. Sometimes you can even see the stomach.
Okay, thank you. So I don't know if locally we have encountered these cases and even management, the outcomes in cases which are like this ones, the giant gastroschisis where there is a liver, stomach, bladder, bowel, which is exoticized.
Yeah, we do encounter some cases. The good thing about a large defect is that it doesn't have associated complications like intestinal obstruction, whereby it can be seen in a smaller defect, which may be also associated with the intestinal atrasias, sometimes volvulus, because of the constriction of the mesenteric veins, and sometimes they may end up having necrosis. The only main disadvantage about a large defect is the abdominal domain. Because of all these large organs, the liver, the bladder, and the stomach are outside. We don't have enough abdominal domain, such that in terms of its management, whereby primary versus stage closure, it's less likely to do a primary closure for this case. These are the candidates that will be good for stage closure. We put a silo bag, we do serial reductions until we completely reduce all the contents into the abdomen. Then we close the abdomen. And sometimes, depending with the size of the defect, it may be difficult to close it completely using the suture technique. We might do conservative management whereby we might apply Maplex dressing or hydrocolloid dressing so that we can want to achieve some epithelialization around the defect. Then later on, we can repair, because later on they end up having ventral hernias. So we do a ventral hernia repair maybe later in life when around 5 or 4 years, around 4 or 5 years old. So in this particular case, considering that they don't have associated anomalies, the prognosis in an ideal setting the survival rate should be around 90%. But in our case, there are limitations. Sepsis, infections, especially sepsis, then also due to prolonged hospital stay, lack of resources, the prognosis may be reduced from 70%, from 90%. But this is a child that in an ideal setting should do well with stage D management, stage D reduction using silo bag, then we plan for closure. Then in terms of complications, long-term complications, besides what you have said, the short bowel syndrome, they tend to do well because with gastroschisis, unlike patients with omphalocele, these are good babies with a bad bowel. Then with omphalocele, these are bad babies with good bowel. Their bowel, for omphalocele patients, their bowel is fine, and we don't have any complications associated with short bowel syndrome, necrotizing enterocolitis, and so forth. But these are the patients who have got other associated congenital abnormalities, such as congenital cardiac defects, which may tend to increase their mortality, unlike the gastroschisis that they don't have associated anomalies. So it's more of GIT complications than anything else.
Just seek clarification. Are you saying our outcomes are that good 70% for this kind of complex kind of anterior abdominal wall defects?
For this or defects, it's only the challenge is that it's just that there's herniation of the liver and the bladder. So it's about in terms of like abdominal domain, in terms of reducing the contents. You'll be worried about compartment syndrome if you do aggressive reduction. So we end up doing stage D reduction using a silo bag. So in terms of prognosis, it's more of the same with the simple gastroschisis, in the sense that they don't have any other associated anomalies. So in an ideal settings, the prognosis can be even go around 90%. But in our case now, because we are going to use silo bag, there's a tendency of having a prolonged hospital stay compared to those who have going to have a primary closure. So because of prolonged hospital stay, whereby it imposes risk to sepsis, they tend to have high morbidity compared to those who have got primary closure. I don't know if I'm clear on that.
Thank you so much, Doug. I think because we have always told our patients that the chances of their baby making it is very low based on the information that we had. First of all, I think one of the studies that was done in low resource settings, the outcome I think was 16%. Then I think Dr. Madzuzo also did another study that was in SA. The survival was not that good for the African region for these anterior abdominal wall defects. Then I think some point with some of your colleagues, we once had a discussion about the outcome of these conditions, and they brought it to us that the survival of the anterior abdominal walls all defects was less than 20%. And one of our students did a study, but she looked at the omphalocele. Again, the survival I think was less than 10% for the patients for the patients we had seen in FMU, and she followed them up. So yeah, so this is why I was double checking with you to say, is it that good for the purpose of counseling whenever we see these women We want them to know what is their chance of the chance of their babies going home if they have one of these defects.
Yeah, I agree with you. It's just unfortunate that in our setting, the survival rate of these babies is not good due to several factors. And so far we don't have a study, but from the study that was previously done, it was around in 20 to 30% in our setting, because of the most common cause of the cause of mortality was sepsis. And it was usually secondary to Klebsiella, gram-negative Klebsiella sepsis. But in an ideal setting, whereby all things are equal, these babies should go home. And compared with the babies who have got omphalocele, their prognosis is much better because they don't have any associated anomalies. So probably if it is a child probably who was in avenues or in other sent elsewhere, this child is supposed to go home.
Right. So, in view of the journey that these parents go through, how should we counsel it? And maybe we'll ask the couple to also come and see you guys. But what kind of counseling should we be having with the couple with this kind of babies? What should we tell them? Or that should help them make a decision. The decision is whether to keep or to terminate. So I'm saying, what kind of message should we tell them? Because the journey is not easy for them if they are going to have multiple surgeries in our public hospitals with uncertain outcome. Should we be pointing? Should we be giving them the option to terminate, or shouldn't at all, and to give them hope to say, look, there's a good chance?
If at any time in Dr. Mtabane will be here, I just want to reiterate what Chidowore has said.
Doc, we can barely hear you. Maybe if you can draw closer to the mic.
I was saying that I just want to add on to what Mr. Chidowore was saying. Gastroschisis ideally has a good prognosis, and it's multifactorial why we have such a low outcome in our. I should say the biggest killer for our gastroschisis babies is sepsis, but there are other things like hydration. Simply because the nursing care is not that vigilant because of the ratio, is that you have one person nursing 20 patients, so they don't notice that the IV cannula is not in or that the NGT is not training properly. So it's the small things really that are killing our gastroschisis patients. Personally, I think we should, in our counseling, give the child a chance. You never know which one will be part of the 30% that will survive. So condemning them before they even try, I don't think it's justified because we know that they should have a good prognosis.
Thank you so much, Dr. Mtabane. There's, I think there are some questions coming from there was a raised hand. Do you want to go on and ask? Please go ahead and ask the question. Dr. Mvuma, can go ahead and ask the question.
Okay, thank you. Thank you very much for this presentation. Firstly, the question that I wanted to ask a bit earlier was to say, at what point do we characterize it as large or small? I've got a case of a 30-year-old in her third pregnancy who's lost 2 previous pregnancies in the first trimester. She's a non-diabetic and hypertensive on treatment, and now in her third pregnancy, the anomaly scan is what has picked up. Well, 2 different radiographers have said it's omphalocele. She's on her way to the fetal medicine unit, hopefully tomorrow. Yeah, so the scan has shown bowel loops mainly being the ones that are in the sac. So, but to say, is it large? Is it small? I mean, obviously the fetal size we're currently at 21, going on 22 weeks. Because like, for instance, the sac is said to be about 3 centimeters in a baby who has a femur length of 3.6 centimeters. So yeah, what exactly do we use to say this is large or small? And then the question that they had was also to say, okay, as this baby grows bigger to the normal term size, assuming no other defects are found, because that's the main concern at this point, to say, are there any other defects besides this omphalocele? Is this sac going to remain roughly 3 centimeters, or is it going to grow in proportion to the growth of the baby?
Maybe Doctor, we can ask Dr. Chidowore to attempt this question first. She's the one who was reading. Dr. Chidowore, do you want to come in and answer Dr. Mvuma's question?
Thank you for the question. So from literature, small omphalocele, they are typically those with a defect which is less than 4 to 5 centimeters in diameter, or often with the only bowel or a small part of the liver in the sac. While large omphalocele are those which are larger than 5 to 7 centimeters in diameter, containing significant portions of the liver and other organs. Then in terms of growth, as the child grows, the omphalocele, like the membranes, also tends to grow, but sometimes the growth of the contents, the viscera, might be more than the growth of the membrane, leading to rupture. In terms of the abdominal wall defect, unfortunately, I didn't come across where there was a mention about it growing or not growing. But if it doesn't expand or increase in terms of diameter to match that of the viscera, which is coming out of it, might lead to strangulation of viscera, or even the vessels leading to necrosis of the viscera. That is what I came across. I don't know if that's...
I think that is what we know from the prenatal side. Maybe we can hear what our pediatric surgical colleagues think of this question.
Okay, thank you very much. Depending with the literature, some literature, they just say if the defect is greater than 3 centimeters, it tends to be a large. But also, we should bear in mind that for a small minor omphalocele, it just contains the intestines. But if it tends to if there is a herniation of the liver, it tends to be a major omphalocele than minor omphalocele. And also it consists of liver or any other abdominal organs, the bladder, the stomach. It tends also to be a major omphalocele. Then the size of the defect, yes, it does have some prognosis. The smaller defects tend to have a better prognosis than larger defects, provided that they don't have any associated anomalies. Like, for example, in isolated omphalocele, with a smaller minor omphalocele, which is isolated, the safe have already to talk about 90%. At the moment that even if it's small and it has got associated anomalies, the prognosis tends to become lower. Yeah, besides whether it's going to grow with the abdominal, the defect, whether it's going to grow as the gestational age increases, it also depends with the growth of the abdominal viscera, whether for example, if the liver is growing proportionally more, the defect tends to get increasing size as well. I think that's all. Any other clarification?
No, thank you.
Dr. Mkono, I can see your hand is up.
Yes, thank you very much, Doc. I just had a question for the pediatric surgeons to say that if our outcomes are consistently bad, why is the recommendation not to terminate? Because the question is, do we make recommendations based on American data, or do we make recommendations based on local data? Is it not a bit cruel to the parents to keep saying the outcomes should be good, but they're consistently bad in our setting?
That is the dilemma. Do you terminate when you know that this child could potentially be the one that survives? Because like I said, they could be born at a time where you have good nursing care at that time in the hospital, and you have very jacked up interns, good IV lines, because we have had a survival rate of up to 50% within the unit, but it can get as low as 20%. And you can never predict at what point that, or what survival rate we're currently at. What we can do is try as much as possible to improve the situation within the unit. Mainly the nursing care, having protocols in place, those kind of little things can help improve the outcome. So telling a mother that your child has a 30% chance of survival, but you don't know which child survives, because it's easier.
I think we have lost you, Doc, there. Dr. Mtambanego, we have lost you. So I think Dr. Mtambanego was raising a point that they are concerned that we may pick the wrong child. One of the reasons why women are given this kind of information, the reason why we want the local data is so that parents can make what you call informed decision making in terms of what do they want to do with the pregnancy. Risk understanding varies from couple to couple. Some couple may tell you that 30% is not good enough. Some couple will tell you 30% is good enough and would want to take the 30%. So that is the reason for wanting to know this kind of information whenever we have these meetings, so that we can tell the couples the correct information to say, look, the chance that your baby will go home is 30%, 70% won't. And also the couple need to be chronicle the journeys that these babies take. If the baby is going to stay 5 months in a hospital, the couple need to be told that the average stay of this kind of baby is 5 months, so that the couple can make an informed decision to say, can they do it or they can't? Well, sometimes the trauma these couple find themselves in is actually nerve-breaking. I think Dr. Kasongo once presented a case of myelomeningocele who wanted to terminate, but because of the legal papers that we have to do, the patient ended up delivering. Dr. Kasongo followed up the couple, and I think he narrated the story and the journey that this couple went through waiting for surgery. I think they waited. By the time he presented, the surgery was not yet done, and they were suffering. This couple, so it's never. There's no right or wrong answer here, but having this kind of discussions help us to refine our approach to this kind of difficult cases where the couple have to make very difficult decisions sometimes. I don't know if we have any other comment. I don't, Dr. Mtabanegwe, are you back?
Yes, I'm back. Sorry, I had another call that came, but I'm agreement with you. It's a complicated decision to make, and I think it should be individualized.
All right, great. If there are no further comments, I think we may end the meeting. Thank you so much to the pediatric surgical colleagues for taking time to join us to discuss this kind of a case. We invite you more and more as relevant cases come along, so that we may tap on your wisdom and your experience, so that you can refine how we work with this kind of cases. Thank you, Dr. Chidowore, for taking time to prepare this case. We really appreciate your effort there. And thank you, everyone who managed to join to participate in this discussion. Thank you so much, everyone, and enjoy the rest of the day. Then for Parenyatwa, use ZFMU. I think Dr. Munya Rutsate is going to come and see you. There's a software we want to try and implement. For now, we are having a glitch with FMF software. We have written to them, waiting for resolution. But there is another software which we want to pilot at the FMU scan, where we know they are not currently not using any system. So hopefully next week we should be able to pilot it and see if it works, the software to capture ultrasound scan information, generate reports. So otherwise, enjoy the rest of the day. Let's remember with the Congress, let's submit our abstracts for this upcoming Congress, the 13th and the 14th. And I take this opportunity to invite surgical colleagues to come and present your work, especially the prenatal cases you are managing, those gastroscopy cases. If your students have done dissertations on surgical cases, please ask them to submit their dissertation with us. I think let's get this message, both our pediatric colleagues and pediatric surgical colleagues, because we would want to know the surgical outcomes of most of these cases that we diagnose prenatally. The Congress is there on the 13th, the 14th of September at Cressa Jameson. So yeah, so hopefully we'll see you there, guys. Enjoy the rest of the weekend. Bye-bye. I think the question posed in the group has already been answered. I can see a question there from Mr. Zhang. I think it has already been answered, that question. Thank you so much. Bye-bye.